the opening of the virtual international conference in Egypt, sponsored by phaco pharmaceutical industry. And now we will start the scientific day, but before that, we must big thanks to our dearest Professor Yahya Salah, who donated his time and effort to organize and supervise this special scientific day. Thank you again, Professor Yahya Salah, and now we start the scientific day. Okay, we can start, Dr. Yahya Salah.
مساء الخير. شكرا دكتور احمد، شكرا لشركه فاركو ان هي ساعدت في تنظيم اليوم ده. انا بس بتاكد ان شيرنج السكرين باين ولا لا. ساره
تمام يا دكتور، تمام.
اوكي. I would like to thank Farco, Dr. Ahmed Saleh, and everybody for attending this mini course on preventing and managing phaco complications. At the beginning, عايز أقول كل سنة وانتم طيبين بمناسبة عيد القيامة، كل سنة وانتم طيبين بمناسبة شم النسيم، كل سنة وانتم طيبين بمناسبة رمضان. So I'm going to talk about my tips and tricks and how to think and manage phaco complications, with a special attention, or actually main attention, on the capsules. Anyone who performs surgery can have complications, regardless of how experienced he is. The first rule: we should not be distracted during surgery for any reason. Otherwise, we are going to get into real serious troubles. Complications of phacoemulsification, it occurs mainly intraoperative, but can lead to post-operative complication. Post-operative complications are usually a direct result of intraoperative complications. And this is what we are going to focus about here. Intraoperative complications can happen in each step, starting from incision until the intraocular lens implantation and even hydration of the wound. So you should be careful, focused in each step to do it in the proper way. What are the most feared complications during phacoemulsification? Number one is corneal. Number two is capsular, either anterior capsular problems or posterior capsular problems. And it's all about the technique and energy management. The less energy you use, the less insult to the cornea, and consequently better post-operative results and safer cornea and clearer cornea post-operative. The more proper techniques you know and awareness of what you're doing, the less capsular problems that can lead to more serious problems later on. How to prevent complications? What I want to convey here is the idea and understanding how to prevent complications. Number one, we should learn the proper technique. We should follow rules for each step. The best thing for anybody, even for younger colleagues who are hearing, is to learn each step and perfect it and then move to the other step. And you should understand the rules of the technique, the rules of each step, how you make the incision, how you do the rexis, how you do hydrodissection. Every step is important. Every step you build up for the next step and make it safer. So you really should understand how you can make a proper step in each part of the phacoemulsification. And don't leave it for just chance or الحظ ان المره دي الحاله مشيت كويس and next time it's not it was bad. So you have to have rules. You have to see well, and this is something I really stress on. I usually recommend my residents and my trainees to work under high magnification. High magnification, I mean up to 1.6 magnification. At the beginning, or for some people, this may be a little bit confusing, but I promise you, this will let you see exactly how tissues behave, how the phaco tip works inside the nucleus, and you will see everything happening. And what is this, why this is important for in our talk in preventing complications, because then you will see properly to prevent complication. You will see complications happening. And in this way, you can prevent even further complications. Don't ever wait for secondary signs. Don't wait that you get a deep anterior chamber, so as you know that the posterior capsule is open. Don't wait for other signs to tell you that you have a complication. If you are used to work with high magnification, you really will identify immediately the complication happening. In this way, you can minimize further complications, and the management will be much easier. So managing complications depend on time of identification, and I have just talked about this. And you should understand what is needed to be done. We are going to talk about this in a few minutes. And you should have the needed tools for whatever you are going to do. And you should be calm. You should not panic when you have a complication, because once you are panicking, you're not moving in the right direction. So let me just revise rapidly some of the rules of some of the important steps that will really help us to perform well and to identify what's the problem and to prevent complications. And the Capsulorhexis, I cannot stress more that the Capsulorhexis was actually a great transition in making phaco safer, because we can work inside the capsular bag, and it's much more forgiving if you have a continuous rhexis. But to do a rhexis, you need to fulfill these rules: deep anterior chamber, holding near the tearing edge, moving every 2 clock hours to be systematic, bringing the flap to the center to avoid extension. In this way, if you follow these rules, it's almost always, it's impossible to have a problem with the Capsulorhexis. If you neglect any of these rules, you will definitely go into a problem with Capsulorhexis. One of the very common places to have the problem is under the wound. You can see here, it's very reproducible thing. You can see that the flap is moving smoothly, and you can create the size and the shape of the capsule you need. But you have to remember these 4 rules. Even to apply these rules in an intumescent cataract, which you can get complications during the Capsulorhexis, like the Argentinian flag sign, using the capsular stain is important, and this is the technique I prefer in doing the Capsulorhexis. You make a curved cut at the beginning after staining. So if the pressure inside the capsule is high, it will push it in the direction that you need, and then you can deflate the bag by aspirating some of the cortex, so you are restoring the pressure gradient in front and behind the anterior capsule, so as your hand or your Capsulorhexis is the main leading tearing agent. There are no vectors that will take you to the equator, and this is a very reproducible technique in such cases that you can avoid the more common a very common complication in such intumescent cataracts. Another important step is the hydrodissection. Hydrodissection, you have to know, and you can see here that you go on into the equator, inject, and you can see the wave. This is in slow motion. With a 27-gauge cannula, you go to the equator, inject, and you have to see the wave. You see this wave of fluid. Just go opposite, 180 degrees, depress, and push the nucleus to allow the wave to pass from the other side. Once you have this done, you see the wave is coming. This is in a slow motion. just to show you that once the wave comes to the other side, usually you don't need to do a lot of maneuvers. The lens, the nucleus, will be hydrodissected. And normally I don't advise hydrodissection if you don't see, like in hard cataracts, for example. And this is an important step to help you or to make you able to maneuver the nucleus during your technique. So let's talk and move a little bit now. I will try to share in the allowed time some of the complications, some are common, and how to think about it and how to go. This is a trainee. One of my fellows was starting. She was very happy. She did a very nice continuous rhexis, but as you can see, this is a very small rhexis. You cannot really do phaco emulsification. It's very risky. You cannot implant the lens. So she is trying to widen the Capsulorhexis, because this is a common problem that younger colleagues, when they are starting, they do this mistake. They want to get a continuous rhexis, but usually because they are afraid the rhexis will extend, they make it small. But no problem. Once you know how to extend it by nicking a tear like you saw, you can enlarge and follow the rules of Capsulorhexis to do the size that you want. Again, this is another, or actually the same trainee. You can see here, she's breaking one of the rules. The anterior chamber is shallowing, because from the wound, this is a common mistake. You depress the wound and you let the viscoelastic comes out, so the anterior chamber shallows. She's watching, she saw here that the Capsulorhexis is extended. This is again in slow motion, just to show you what will happen. She will go. The ideal thing to stop this extension, to inject viscoelastic peripheral to the extension and then inflate the back. You see here, she's injecting while she's going. So the Capsulorhexis is actually extended, the tear extended to the equator, and it's much more difficult to deal with it afterwards. So it's just understanding where should I use, you put the viscoelastic, how to identify the tear, and then how to move. And then here is making a nick from the other side, and she's trying to solve the problem. If it is, you don't have a senior with you, you can convert to extra capsular. This is an example, another example. I just want to stress on the rhexis. This is again one of my younger colleagues. You can see hesitant in holding the nucleus. He made a vertical cut in the anterior capsule. Everything now looks fine. Holding near, you should hold near the tearing edge, not at the tearing edge. Everything is going fine. Look here, he's stopping at the wound. You should. That's why we give the notion of moving every 2 clock hours, because if you reach the wound, you lose some viscoelastic, and this make it difficult to see and manipulate the tear. So here he has to stop. You see it's extending, so you have to notice that it is extending. And then you try to hold. Look here, he's holding away from the tearing edge. And here is the zonules. You see, just because the direction of tear, he was lucky a little bit that he could control it, and pulling as a radius, diverted the tear into the right place. So you have to be very meticulous following the rule. Have deep anterior chamber, so as you control the rhexis. And move every 2 clock hours to be systematic, so you can hold it and you're not squeezed under the wound. Another example, here you can see this is an intumescent cataract. You see, using the cystotome, doing fine. Of course, you have to learn how to use the cystotome, or you can use the Capsulorhexis forceps. It's sometimes you need to change. in between them, and he is moving very hesitant, again getting too far away from the tearing edge. In such cases, it's always better to catch the flap near the tearing edge. Here, injecting viscoelastic, again, you should inject peripheral in this area, not here at the beginning. But so far, everything so good. He's trying to do this with the cystotome. Not much control, and notice there is pressure from inside the lens because this is an intumescent cataract. You see, trying to move the pull. You see, the pull was incorrect, the direction of movement, the shallowness of the anterior chamber. So that's why the rhexis is still going to the equator. Then he stopped, and tried to move in the right direction. You see here, he did not solve the problem because he did not equalize the pressure in front and behind. Now he's thinking of doing aspiration. As you can see, the aspiration here has nothing to do with the area of the problem. He's doing aspiration. This is used, it's already opened capsule. What he should do, you can go from the paracentesis, go and aspirate under the capsule, which is you are still tearing. So as you can see, it's already extended. And this is again wrong technique. You see that the tear is extending to the periphery. What you should do, you should hold it near the extending edge and just rip it to the center. This is wrong direction of pull, losing viscoelastic. How I know? Because you see there are loss of viscoelastic through the wound. This, if you see this corneal striae, it means you are losing viscoelastic. Some of the important things to prevent complications, to see problems before it happened or difficulties before it happened. This is in a slow motion. I just want to see that this is a typical sign. The fault sign is typical of subluxation. So once you do the holding the Capsulorhexis and you see that there are folds in the anterior capsule, this means immediately this lens is subluxated, and you should change your strategy, lowering the bottle height, working in slow motion, preparing other tools like capsule tension ring or 3-piece lens. So when you see these folds, it's a typical sign of subluxation. So if you know it, if you see it, you can prevent complications. Another problem is fibrotic anterior capsule. You want to have a continuous rhexis. You want to deal with the small capsule as well. One of the things that you can deal with the small pupil in such cases, 2 microsphincterotomies. Of course, there are multiple ways to deal with this. This is a very hard cataract. You have to have a continuous rhexis. There is no way to go safely without doing this. Here I'm staining the anterior capsule, and the problem in this case is that you have this fibrotic strand in the anterior capsule. You cannot tear it continuously, so you have to cut it. Here I'm cutting the anterior capsule, and then you have to cut this band and then complete the technique as usual. This is very important to identify that you have a different situation, a different pathology. So try to change the situation which is abnormal into as much as possible what is close to what you are used to do. You see, after we cut with a sharp scissor the fibrotic membrane, you can continue your Capsulorhexis. Whenever you are met with a fibrous membrane, then you cut it and then continue with the Capsulorhexis to be able to have a continuous cut in the anterior capsule to deal properly with this extremely difficult nucleus. Okay, these were examples of the anterior Capsulorhexis problems, but once you have the rules, you cannot go into complications. Let's move a step forward. Hydrodissection is important that you are able to rotate the lens so you can deal with the nucleus with the metal phaco tip in the place that is easy to catch. The metal tip is not bent, you cannot bend it. So you cannot go under the wound to do phaco emulsification. So hydrodissection was a very nice step that we learned to do it to allow us to rotate this nucleus. but it can have problems. That's why I showed the rules of hydrodissection. If you miss the rules of hydrodissection, then you will get into a problem. And this is the easiest problem, that the lens will not rotate. But the most serious problem, look here. Just watch, this is a simple case, hydrodissection. And now phaco-emulsification. It looks as a simple, straightforward case. It looks like nothing happened. And lens is not moving properly. Now the step of cracking the nucleus, and now nucleus is into the vitreous. So what happened? Actually, look here, you will see like an explosion in the center. This is the wave. This is in slow motion, see? Wait, now. Look here. It's like an explosion. And this is called capsular block syndrome. You have to see it once to avoid that you don't see it again, because it's a really bad complication very early in the surgery. So it's very important to be aware what happens if you have a small rhexis, bigger nucleus, injecting forcibly. You don't give time for the wave to pass to the other side of the nucleus. And that's why the technique, the proper technique of hydrodissection is not just injecting. You have to see the wave passing to the other side. And what happens in this complication, that you inject hydrodissection fluid, it accumulates in between the nucleus and the posterior capsule, which is very thin, and you keep injecting because the nucleus is not moving, and then it comes to a point that the nucleus will rupture, and the rupture will let the fluid go into the vitreous. Sometimes you'll see shallowing of the anterior chamber, or you will not see anything, and then you will be surprised that the nucleus is dropping once you start phaco-emulsification. So it's not a common complication. You have to know about it. You know the technique to avoid it, because it's a really bad complication. So let's move to our main field complication that everybody can have it, and we try to understand how to prevent it. We should know that during phaco-emulsification, 59% or 60% posterior capsule rupture occurs during phaco-emulsification, but don't underestimate irrigation aspiration. It's up to 25% of posterior capsule rupture occurs during irrigation aspiration. So we have to be aware that it is a problem, and this problem can cause a lot of further complications, whether to correct the cataract, the placement of the lens, or it can induce further complications that need vitreoretinal interference. The posterior capsule rupture can happen, as we saw, at any moment from hydrodissection. Can happen early during the phaco-emulsification, midway, or late. So let's talk about the idea or the principle of how to prevent posterior capsule rupture. Number one, again, as always, proper technique of surgery, proper technique of moving from one step to another, proper technique of handling the instruments, the phaco handpiece, the chopper during surgery. Good visualization. Again, I want to stress once and more for the good visualization, good magnification. You can see well, you can see the posterior capsule. In normal cases, you will understand how the posterior capsule behaves. Normally how it behaves, and abnormally how it behaves. So whenever you see you have a complication, you will identify it. If you catch the posterior capsule, you can stop in the proper time. But even if you open it, you will see it in the proper time. See the problem happening. Don't wait for secondary signs. Be calm and think systematically. Whenever you have a posterior capsule rupture, you should always ask yourself, is there vitreous loss or there is no vitreous loss? Because it's very important to decide immediately if you have vitreous loss or not, and accordingly you are going to manage. You are going to use the tools that you have to reach the final result. Let's move along different scenarios, whether early or late. It looks a straightforward case. Look here, the chopper, how deep it is. Still, it's not, pupil is not very widely dilated, but everything looks normal. The vacuum, we're using low power, high vacuum. The groove, trying to rotate the nucleus. You can see here, this is in a slow motion. You see, there is a capsular tear. You don't wait to have further complications because you are used to see well, you know how the tissues behave. You can identify it very early. So once this happens, you try to stop. You can change. If you are holding part like this into pulse, you see the tear is opening, widening. This was wrong exit. You should not pull out the phaco tip once you identify the problem. This is very early opening of the capsule. Still have nucleus. My main worry, I don't want to lose this nucleus into the vitreous. So you stop, inject viscoelastic, try to prolapse the nucleus in the anterior chamber, widen the incision a little bit, and then using the Capsulorhexis forceps, which I think it's a very useful tool to hold nuclear fragments or to crack nuclear fragments even with using the chopper or spatula. And this, you can see here, I'm identifying there is vitreous. Vitreous strand was here. You have to make sure that you remove it. The sweeping movement we're going to see a lot in this lecture with the iris repositor is the best way to identify any prolapsing vitreous strand into the wound that was preventing the nucleus fragments of coming out. So I did cut it with the Vanessa scissor, and then you see this is the movement. You can see here a vitreous strand. You don't need to stain. I'm cutting with the scissor just to release this and then checking what I have left. I don't want any fragments to fall. Now there is vitreous. I'm doing through the paracentesis, vitrectomy with high cutting rate, starting a little bit deeper to prevent prolapse of the vitreous. And then once I clear the vitreous, I can do irrigation aspiration, and you can alternate. يعني ممكن تقلب من irrigation aspiration للvitreous. And then after I clean up everything, I check the posterior capsular remnants, even if the capsule is, the pupil is narrow. Here is the 13 millimeter one-piece lens. Nowadays, we prefer in a way to implant in the sulcus 3-piece lenses. But still, once it's a proper size, you can go with it, and it's implanted in the sulcus in front of the remnants of the anterior and the posterior capsule. And you create always, before implanting the lens, a space with viscoelastic in different quadrants to make sure that the lens will go in front of the remnants of the capsule, not behind the remnants of the capsule. Again, look here. This is another example, early posterior capsule rupture. Here is the phaco going up. You'll see everything finished, and you immediately identify a huge tear in the posterior capsule. Huge tear. You stop. Again, not the best way to go out, but here I'm checking how bad is the opening. It's completely huge opening, but there is no vitreous, which is good. So I inject viscoelastic and decide to change my plan of the lens. This is a very old movie. I'll make use of all the remnants to implant a PMMA lens in the sulcus. This is later on posterior capsule rupture. You see there is epinucleus, part of the nucleus still there, epinucleus. Everything is going fine using high vacuum, low power, using the normal vertical chopping technique I use. Everything is going fine. You can lose concentration in a second, and then you have problem. I'm almost finished. Observe carefully. You see, here is a tear. I did not block properly the tip with the nucleus fragment with a high vacuum. Then the flow brought the capsule into the tip, and this is made this large tear in the posterior capsule. What is remaining is epinucleus. You see here, I kept inside with the infusion on, injecting viscoelastic to avoid prolapse of the vitreous. This is the proper technique when you want to go out after posterior capsule rupture. I went out, I kept infusion, and then injected viscoelastic and replaced it by removing the phaco tip. Then now I'm doing dry aspiration. I can see the tear in the posterior capsule. There is no vitreous, so I inject with the cannula viscoelastic, and with the aspirating cannula, I'm aspirating what is remaining of the epinucleus and the cortex. And always try to inject viscoelastic, as you can see, to avoid rupture of the anterior vitreous face and consequently vitreous prolapse. You see, it's a huge tear in the posterior capsule, but I have a perfect anterior capsulorhexis, so I can implant in the sulcus. You can do capsular capture, or you can implant in the sulcus, just in the sulcus. And it's very important is the first haptic to make sure it goes in front of the anterior capsule, not in the opening of the posterior capsule. And then after inflating the anterior chamber with viscoelastic, you can perfectly rotate the lens into the proper position and to make sure there is no vitreous strands. But rupture can happen with vitreous. One of the important signs that you know that you have vitreous or not from the first moment is to see rounding of the tear in the capsule. This rounding tells you that there is rupture in the anterior vitreous face and there is vitreous knuckle coming out. So you have to be careful not to continue phacoemulsification or irrigation once you have vitreous. Otherwise, you're going to attract more vitreous and pull on the vitreous and consequently on the retina. Here, this is a very early identification that there was an opening in the posterior capsule and there is vitreous because there is rounding and a big chunks of the nucleus are present. The most important thing here is the identification that the posterior capsule was open. So now the same technique, injecting viscoelastic, trying to avoid any loss of a nucleus or enlarging of the posterior capsular tear and having more vitreous. Now I'm injecting, widening of the wound, trying to tamponade this vitreous opening and trying to prolapse out whatever will come from the nucleus or epinucleus. And with the viscoelastic, I'm tamponating that. You see, this is the opening. You see, it's rounded. It's obvious there is vitreous. Once you reach this stage, then you will have to start using the occlusion or vitrector with the rules of vitrectomy. You see, this is now using the spatula, bringing back any vitreous strands. And with high cutting rate, low aspiration, high cutting rate like 1,000, 1,500 cutting rate, with vacuum 200, 250. If you're using 20 gauge, now we are using 23 gauge vitrectomy probes, which is very nice because it goes in smaller area and you can actually go through the sclera, because you can do the vitrectomy through the anterior approach, which is very common, or you can go pars plana, but you have to be a little bit trained for this. And sometimes the tension, if it is soft or the pupil is narrow, you will not be able to do it easily. Here, I was switching of the vitrectomy into irrigation aspiration to remove the cortex. Now I had the opening in the capsule. I'm checking by sweeping that there is no vitreous strands. You don't need to do staining of the vitreous. And this is, in my opinion, this is the best way to make sure that you don't have any strands. Injecting kinecort usually distorts the visualization. Now I'm removing any vitreous strands coming out. Then identifying how big is the opening. Should I implant the lens in the back or in the sulcus? Which type of lens? The most important thing to learn in that case that it was identified in the proper time. There is no further complications that happened. So, and the management was swift. Let's see another problem. This was a colleague of mine who called me. He said, I don't know, I think I lost a part of the lens, but everything is good. This was a mature intumescent cataract. When I said I didn't see, I'm checking now. Checking what is the problem, where is the opening of the capsule. I didn't see it happening. So I'm checking what's this, a lot of cortex, epinucleus. I don't see the nucleus. He said he didn't do much phaco. So you have to be observant here. Look, you can see a shadow of a nucleus here. So I will do indentation. And I found the whole nucleus has dropped, has fallen into the anterior vitreous. And it's lucky that it's not falling back, but you have to identify that the nucleus is there by this indentation. Now, there is no other solution except doing the PAL technique. This is posterior assisted levitation. I went into with the MVR, directed first into the mid-vitreous, then moving to hold the nucleus, preventing it from falling down. Then, with the other hand, you have to widen the wound and to try to deliver the nucleus or the whole nucleus, because your nightmare here is that you lose the whole nucleus. So first things come first. You have to think how we are going to remove this nucleus, and then you check what is left and what are you going to do to visually rehabilitate this patient who will coming for cataract surgery. It's not easy because you're using both hands, and the one in the vitreous, you are holding the nucleus and trying to deliver it into the anterior chamber. So it's a bimanual technique now, injecting viscoelastic to protect the cornea. And I will prefer to use a Vectis. You can see here, you have to widen the wound. The nucleus is being held by the MVR at that time. And now I'm trying to deliver the nucleus in the anterior chamber a little bit, just to be able to catch it with a Vectis, just to hold it and get it out of the eye. See, this is the left hand, trying to hold the lens, injecting a lot of viscoelastic, again, to protect the corneal endothelium, because when you are delivering the nucleus, you might actually insult the corneal endothelium markedly. Particularly, it's a ragged nucleus. It's not smooth. Now, this is the Vectis, and you have to make adjustment of the wound size. You will not be able to do it while you're going out, so you have to stop. Maybe you need to enlarge the incision. Again, enlarging the incision when I saw the size of the nucleus. This is half of a nucleus. And then the second half, you rotate it vertically to come out from the smallest possible size of the incision. Now, it's you take a breath and it's everything later is a little bit easier, but now you are trying to get out the epinucleus, the cortex from inside the eye, and then try to evaluate how bad is the situation. Is there any remaining part of the capsule after this heroic maneuvers? And my colleague have done a proper rhexis, anterior capsulorhexis, which was very helpful in such case. See, this is again using the sponge here just to check and cut. Still, up to now, this is an important maneuver, just to cut the prolapsing vitreous here before you enter inside. And then in an old patient, it's better to lock the wound, at least with 1 or 2 sutures, to avoid the extreme hypotony and the risk of suprachoroidal hemorrhage, which is really a more serious complication. So you have to think of other complications that can happen. Then you here with the anterior, with the vitrector, high cutting rate, low vacuum, cleaning up cortex. You can see here floating parts, and cleaning as much as possible. You don't want any vitreous in the anterior chamber or going as a strand through the paracentesis or the main wound. Again, after finishing this, the anterior vitrectomy, with the iris repositor, you sweep from periphery to the center to see any vitreous remaining that you can remove afterwards. You see, this is the most important maneuver. You will see any vitreous strands. It's not injecting air. It's not injecting dye. This is, you are sure, you are really seeing the strand that is preventing proper implantation of the lens or posing problems afterwards. Here I am putting a 3-piece lens. This is a sensor lens, foldable, but because of the nice design of the haptics that can fit very well to the remnants of the capsule, and this is now a 3-piece lens, so I prefer to use it through this incision, and to make sure that the lens is implanted in the proper place. You have 2 options here, either to put the whole lens in the sulcus, or you can see here the anterior capsule rim. You can implant the lens optic into the capsulorhexis if you have a proper capsulorhexis. This is called lens capture, and then leave the haptics in the sulcus. So you have 2 options. And here I'm checking again after implanting the lens. If there is any vitreous strands present, you have to remove it immediately intraoperative. Don't wait for next day problems. You have to make sure, don't worry, because you can see the remnants of the capsule, you can see the position of the lens. Make sure that the lens is positioned properly during surgery. Don't say, alhamdulillah, ana hatit al-adsa, I put the lens, and then you go away because you're afraid. You inject myocol, for example, and it will look nice for a few minutes, and then in the first post-operative, you see the lens displaced. And very common in such cases, just a vitreous strand in the periphery prevents the lens from proper centration. So let's take another scenarios, and at the end of irrigation aspiration, see, slow motion. Look here. Look here, I'm holding the posterior capsule, and it was behind the cortex. So actually, again, now you can see a tear, and with this tear, it is identified immediately. I still have a part of the nucleus, irrigation aspiration. This was hiding. I made the proper technique of going out, injecting viscoelastic, and removing the irrigation. Now I'm checking if there is vitreous or no vitreous. I'm sorry. checking if there is vitreous or no vitreous. So here I'm inflating, there is no vitreous. I'm inflating the bag with viscoelastic. You see the tear is irregular, large. There is part of a nucleus that was hidden under the iris. I removed it with the Capsulorhexis forceps. There is remnants of a cortex. So I'm removing it with dry aspiration after inflating the bag and the anterior chamber with viscoelastic, observing the tear, avoiding it to increase, and at the same time, you don't want to disrupt the anterior vitreous face. Then you can evaluate. This is a tear in the periphery. You can implant the lens actually in the back or in the sulcus. The same lens can be implanted. You have to be careful if there is remnants from the posterior capsule that can support the haptic or not. Very slowly injecting the lens and then rotating the lens in the proper position. So you can see even during irrigation aspiration in the later parts, you can have a problem. What made a difference here is that the problem was identified once it happened. What difference did this make? It made it possible to have this big tear without vitreous loss. Another example of how posterior capsule can be ruptured if you lose concentration at the end of the surgery. Again, this is irrigation aspiration. The case is ending. Everything is fine. No obvious problems. You're ready for the next case. And look here. Irrigation aspiration, Capsulorhexis is intact. Here you see the aspirating cannula, and in a slow motion, you can see that I hold the posterior capsule and pulled. The irrigation can will not open the posterior capsule if you just stop there. If you pull your hand, mechanically you will tear the capsule. So now, again, I'm going out, keeping the infusion until I inject viscoelastic. It's obviously there is no vitreous. I don't want more vitreous. Why it is obvious? Because it's a straight tear. The tearing, there is no rounded edges in it. Injected viscoelastic support to inflate the bag and support the anterior vitreous face. And as I can see, the extension of the capsular tear here with high magnification, actually, this is just a snip of a strand. So injecting viscoelastic. And now I'm going to convert this peripheral tear into a continuous posterior Capsulorhexis, following the same rules of anterior rhexis and posterior Capsulorhexis that we can talk about it in another lecture. You see, injecting viscoelastic, following the posterior capsule, converting this ellipse tear into a posterior Capsulorhexis continuous. So what we have now, we have a rounded opening in the posterior capsule, no vitreous loss, and some cortex remaining. You can implant the lens now in the bag and then do irrigation aspiration, or you can do dry irrigation aspiration. Here I opted to implant the lens in the capsular bag. And why I can implant it in the capsular bag? Because I converted the opening, the tear, into a continuous circle that will withstand the maneuvers in implanting the lens inside the capsular bag. And this was the primary intention of the surgery, to implant this lens in the bag. This is a nice lens. This is the thickness lens, which is hydrophobic, and the haptics unfold slowly. So this gives you time to manipulate the lens before it unfolds completely. Doing irrigation aspiration and making sure the lens in the bag, and then the case end rapidly because you have seen the complication happen. This is again one of my residents. Excellent surgery he did and now he's doing hydration, like I told him, to clean the posterior capsule from lenses. It is ready to inject viscoelastic to implant the lens, and oops, but you can see that it's a huge tear. The mistake here, he was so excited, he finished the case. He did not make sure while going with the viscoelastic is to inflate the bag to make sure that he have injected some viscoelastic to push away the posterior capsule. He just catch it and inject it. So he made this huge tear. Then we check the vitreous as was seen in a moment ago. Checking the vitreous here and injecting viscoelastic. You can see the tear is huge, irregular. I'm trying to remove this cortex. But again, the problem was, there was a problem, but what was identified in the proper time, why it was identified in the proper time, because of training of seeing in a good magnification, you can see the problem happening. If he did not see it, he would implant the intraocular lens into the vitreous directly. But because he saw it, he stopped. Then we started managing, checking, asking ourselves, there is vitreous or no vitreous? And then the lens carefully is placed, either optic capture, in the sulcus, whatever the situation allows you, to make sure that you have a safe placement of the intraocular lens. This is again just a rapid reminder, anterior capsule tear here, but I was unlucky in such case. So again, the posterior capsule was opened, following the rules of posterior capsulorhexis, turning the posterior ellipse or spindle-shaped tear into a continuous rhexis by injecting viscoelastic behind the tear, pushing away the anterior vitreous face and in front of the capsule to allow you to be able to tear the posterior capsule to make this spindle shape into a continuous circle that you can implant later on the intraocular lens wherever you plan to. And this is very important to manage in the proper time. We are about to finish, just to share with you some of the interesting more complications that I would like you to avoid. This is a very rare situation. It's called long anterior. You can see the zonules are very near, very central, all these zonules. So I saw this was a straightforward case. I never saw this before. So I said my problem probably will be doing a continuous capsulorhexis. My problem in such case, I thought, will be doing a capsulorhexis. It's a very small area of the anterior capsule, clear from the zonules. So actually, I started the surgery. You can see this is the area I can work in. Observe. See, the anterior capsules are very much central all around. You have to see this to be able to remember such a case, to avoid complications. See, I'm doing the rhexis very carefully. I'm trying to make it smaller. You see, I'm very careful. I don't want to tear the zonules. I'm doing fine. If it makes a problem, it would make it extend to the equator, but I'm trying to be very careful, and I'm thinking all the time, this is my only challenge in such a case. Look here. You see, this is the end part. Look at the zonules here. You see, the zonules is dripping off. This is in high magnification. You can see I'm tearing off the zonules. Although I got a continuous rhexis. Because I have never seen such a case before, I continued as usual, and I thought I finished the major problem in such case. And while working, this is a little bit fast forward, doing my regular technique, I noticed that everything is just moving. The whole bag is moving from everywhere. So I thought, Okay, now I have zonulitis. Maybe I can put a capsular tension ring. I'm trying to get whatever cortex there with viscoelastic. I don't want, up till now, I don't want to open, to have vitreous loss. I'm thinking, all the time I'm thinking, would I get a capsule tension ring, capsular hooks? But everything was happening faster. I said I would remove the epinucleus, and now you can see the whole back is detaching. You can see here where the arrow is. The whole back is detaching. What is remaining is only cortex. So which is the best way? I was wondering, what should I do? So up to this moment, you can see I can inflate the back, but there is no support to the back whatsoever. Later on, I would think the best way is to put capsule tension segments at the beginning of the surgery, or double Sion ring and suture it to the sclera at the beginning before doing anything. Now I'm trying to get everything out. I realized I will not be able to keep the bag. Checking for vitreous. You can see vitreous here is strands, so it's coming around the area of zonulitis. Doing anterior vitrectomy. And now I remove the whole bag. There is no capsular support. What should I do? Should I use an anterior chamber lens, Yamani technique, sclera fixation? Here I opted to use posterior enclavation of an iris claw lens, which is a good option. This abnormality is called long anterior zonule syndrome. It's rare, but you can see it as total like this one or partial. And the most important thing that these patients develop usually secondary glaucoma for a genetic predisposition post-operative. So you have to observe the intraocular pressure in such cases. This is another example. This was a Down syndrome and a patient that had mature intumescent cataract. We could not examine until he was asleep properly. Now I'm doing starting the phaco. You can see the lens is moving here. This is the importance of observation. There is vitreous here. So you stop completely. I'm going out. Again, mistake. So going out immediately induced the rupture of the anterior vitreous face, and the vitreous is out. Now what I have is vitreous loss through the zonulitis, like 3 hours. The whole nucleus almost is there, but there is intact anterior capsule, and the whole back is intact. The way of thinking is to think step by step. Now I want to get rid of the vitreous. So I did the lens. Once I did this, the lens got back into position. So you think, would you need support to continue the case or not? I'm widening the paracentesis to be able to do from it anterior vitrectomy to make sure there is no vitreous strands that will keep the lens away from its proper position. So, and this sweeping movement with the cannula acts like the repositor. And then you can see that I lowered completely the infusion and everything is going in slow motion. And I was preparing a capsule tension ring if I needed, but everything was going slow, fine, and I'm observing all the time, expecting the whole back can come into the phaco tip. So at the end, everything is going extremely low, slow motion, and you can see that the infusion is low to avoid more problems or bad fluidics in this particular case with an area of zonulitis. Very slowly, I can see the bag is intact, completely in place almost. So I only have some cortex. I will wash it. And then you can ask yourself what to do here. Either you can put a capsule tension ring and then one-piece lens in the bag. You can put a three-piece lens into the sulcus. Or as I opted here, after cleaning and washing this cortex and cleaning the bag, because I don't want to do too much stress on the zonules before supporting the bag, because during phaco, the nucleus was supporting the bag. Now I'm doing irrigation aspiration very carefully, very slowly, with the infusion into the inflating the bag. I loosened as you saw in the previous maneuver, I loosened the cortex to make it easy. Now evaluating the back, it's intact, inflating the back, and I decided here to use a 3-piece lens to implant it in the capsular bag, and this 3-piece lens is 13 millimeter overall diameter, and it will act exactly like a capsule tension ring. Of course, there are arguments in some of these cases, but this was a 55 years old, that they might have a progressive zonulysis, but in this case, as he presented late with the lens in place, I opted to implant in the back the 3-piece lens. And here I'm checking again, as always, if there is vitreous strand from the zonulysis area that is preventing this lens to be centered properly. So after sweeping, doing vitrectomy for the strand that you saw, then repositioning again the lens in the capsular bag after inflating the capsular bag with viscoelastic to be able to rotate and maneuver the lens without stressing the remaining zonules. This is again another colleague, a colleague that was doing this case, hard cataract, asked me that she feels there is subluxation, so I restained the capsule. I found it a little bit, the Capsulorhexis was the small pupil getting down. I am enlarging the capsule to do a proper Capsulorhexis, and then watching what is happening. I'm trying to go slowly to remove the nucleus, which is hard, supporting the back. And then I started to notice, because the pupil is now I can see that this lens is very much subluxated. So it's not safe. So you stop, you watch the problem, you stop, you think how to solve it. You have many options, but I chose to put capsular hooks, which are blunt and long, that can support the capsule. And once I'm supporting the capsule in the area of weakness, where its zonulysis is, then I can continue in a slow motion my phaco emulsification, observing very well the posterior capsule. As you can see, the magnification is helping me to occlude properly the nucleus and observe well the posterior capsule. Now, before removing the capsular hooks, I'm putting a capsule tension ring, which is 12 millimeters in diameter, and then implanting a 1-piece lens into the capsular bag as the plan was originally made. So, and then after implanting the lens, I remove the capsular hooks, which are very, very useful tools. Checking again the lens in place in the capsular bag. The capsule tension ring is supporting. So this is a very good demonstration of how you should think even in difficult situation, and you can move in a systematic manner. My colleague, she felt not comfortable, so she stopped. This is the right decision. She asked a more experienced surgeon. So I checked, I tried to identify the problems and tackle it one by one. Number one, small rhexis, I enlarged. Number two, trying to do phaco emulsification, observing this zonulysis, stop, and put capsular hooks to support the nucleus. Then continue phaco emulsification, and then put capsular the capsular hooks. There are examples. Whoever works surgery will see complications. Not zero complication, but to minimize the incidence of complications, and at the same time manage the complications in the proper time. Managing the complications in the proper time will get the proper results. So anyone can get complications. It is better to avoid the complication by using proper technique and using good high magnification, because you understand what is going on. Early and proper management is key in achieving good results, whatever complication you get. Thank you for your attention. كل سنة وانتم طيبين. دكتور احمد